We can start now.
Good afternoon to all. Today we are having the Chief Minister's Roundtable on COVID-19, and I am extremely happy to welcome all the participants to this roundtable. Honorable Chief Minister Sri Pinarayi Vijayan Sir, Honorable Minister for Health and Family Welfare, Government of Kerala, Srimati Veena George, and several experts and officers are participating in this meeting. As all of us are aware, Kerala has been taking up the COVID challenge with a number of measures, and several steps have been taken in a manner such that we have been able to contain COVID-19 in an exemplary manner so far. Our fatality rate is one of the lowest in the country with 0.51%, and our vaccination rate has gone to 73% with the first dose of the eligible population and 27% with the second dose of eligible population. As it has been brought out in the seroprevalence surveys in the country so far, the immunity level is achieved only for 42.7% of the people, indicating that the infection so far has been contained in a substantial measure as compared to 68% of infection rate at the national level. And at this point of time, we are faced with the challenge of dealing with mainly the Delta virus as well as the Alpha virus, these are the two strains which are dominant here, with the most dominant strain being the Delta virus. Now, in the times to come, we have further challenges in terms of the likely indications at a global level about a third wave. Though our second wave has subsided substantially, we are still faced with a substantial infection rate on a daily basis. So, on this situation, the Honorable Chief Minister has been taking daily conferences and various review meetings with all the officers, and he has been leading the fight against COVID from the front. In order to have wider consultation on this issue, we have convened this roundtable with the experts, and I am extremely happy to welcome the Honorable Chief Minister and the Honorable Health Minister to this roundtable. I am happy to welcome the various experts from different parts of the world. Dr. Bharat Pankania from the University of Exeter Medical School, Dr. David Peters from Johns Hopkins University, Dr. Patrick Oseve from the Asian Development Bank's Health Sector Group, Dr. Devi Sridhar from the University of Edinburgh, Dr. Ajay Mahal from the University of Melbourne, Dr. Sangsap Ra from the ADB, Dr. David Wilson from the World Bank, Dr. Ganga Khedkar from the ICMR, Dr. Agarwal from CSIR, Dr. Jacob John from CMC Vellore, Dr. Gagandeep Kang from CMC Vellore, Dr. Sanjay Pujari from Pune Infectious Diseases Institute, Dr. Chandni from State Medical Board Chairperson, Dr. Anup Warrior from Aster Medicity, and Dr. Iqbal, who is the chairman of our expert committee, along with other officers and colleagues who are attending this conference. We are thankful to your valuable suggestions and opinions, which will help us in taking this COVID discussion forward. Thank you all.
distinguished experts from various countries and from within India and Kerala. Namaskara. All of us are gathered here to share experiences and insights on COVID pandemic control, mitigation and strategy for the future. I am sure that your strategic suggestions based on your collective wisdom will help strengthen the fight against the pandemic, and we will come out of it soon. Kerala's battle against the pandemic has been a collective one, involving all agencies of government, organizations both in the public and private sector, and involving large-scale mobilization of the community. The fact that over 50% of Kerala's population is sero-negative as per the ICMR, even after a strong second wave across the country, is indicative of a strong people-centric approach towards COVID mitigation. Our pandemic response has always relied on scientific expertise and knowledge gained across the world regarding various interventions, including non-pharmacological interventions such as restriction of mobility and lockdowns. However, the measures such as lockdowns, restricted mobility have adversely affected livelihoods. The health department has been continuously providing treatment, care and support to tackle other non-COVID diseases, but it is a fact that various disease prevention programs have been impacted. Kerala has achieved the distinction of administering at least one dose of the vaccine to more than 74% of its adult population. The remaining 26% will also be inoculated within the next month or so. In the light of these developments, the government will have to focus on non-COVID care and restoration of livelihoods while remaining vigilant against COVID. Our children have been out of school for more than a year now. It is time we start serious deliberation on safely restarting education institutions. Unless we focus our attention on the long-term impact of the pandemic on various segments of society, we will find ourselves under-equipped to face the challenges of the post-pandemic years. It is against this background that working around COVID gains importance. We look forward to the deliberations for guiding us on the way forward for containing infection, improving strategies in testing and vaccination, enabling mobility, and ensuring education. I look forward to hearing from all of you on the major themes outlined in the discussion paper prepared by our team. Thank you.
Honorable Chief Minister of Kerala, Shri Pinarayi Vijayan, and distinguished guests, experts from different parts of the world, my colleagues, dear brothers and sisters. It's a matter of greater privilege for the state of Kerala that we have distinguished guests of higher standing to come together to review and discuss on the COVID pandemic situation. The government certainly appreciate the trouble and interest taken by each and every one of you in marking your presence here. Wholeheartedly, we welcome all of you, and words are hardly enough to thank you for the greater inputs that you would have in anything that we are discussing here. As our Honorable Chief Minister has explained the main objectives of this meeting, we look forward to your suggestions, to your valuable suggestions to strengthen the fight against COVID pandemic and actions to be taken in future as a long-term measure. Kerala, right from the first case, has been taking various measures to contain the pandemic and taking various mitigation interventions to the best of our abilities. The response was coordinated also with active involvement of local self-government, police department, revenue department, civil society, volunteers, and people. I would like to invite your attention to the pandemic trajectory of the state. The first case in the country was reported in Kerala back on January 30th, 2020. In the month of December 2020, during third round of ICMR zero prevalence, around 80% of Kerala's population was zero-negative. Even after the highly infectious Delta virus surge during second wave in the country and in the state, ICMR's fourth round survey indicated that around 50% of the population in the state is zero-negative. This is the result of public action coupled with proactive governance, control, and mitigation activities. I feel it is a classic case study to see the delaying of the peak and flattening curve approach. So far, we have detected 4 million positive cases in the state, and out of which 3.8 million has recovered from COVID. Today, with total active case pool of 2 million, hospitalization of moderate to severe cases is around 2,825. Field hospitals are created to support the health infrastructure in the form of COVID first-line treatment centers, COVID second-line treatment centers, and domiciliary care centers. And the total number of patients in these centers comes around 18,259. The case detection and the testing rates of the states are high. We could cover over 73% of the total population above the age of 18 with first dose vaccine. Special vaccination drives were organized to vaccinate people above the age of 60, bedridden patients, and people with comorbidities, etc. Also, we have taken certain initiatives covering the elderly on old age homes, destitutes, mental health centers, transgenders, etc. We are planning to cover the total population of 18 years and above age with first dose by the end of September. And as per the availability of vaccine, we'll be completing first and second dose of vaccination. The seroprevalence study shows that, as Honorable Chief Minister has mentioned, more than 50% of the total population is still unaffected. Kerala also has the highest density of population, which comes around 859 per square kilometer. There is no difference like urban area or rural area in the state. All places are almost the same. Also, the proportion of senior citizens in our population is 14.6%. Kerala has the highest percentage of non-communicable diseases also. All these factors contribute to the vulnerability of the population, which indeed is high. We are looking forward to your valuable suggestions on certain points, which will help us refine our strategies and containment measures. And first point is the mobility restrictions. Wearing masks, using sanitizers, observing social distancing, etc., have become a part of our lives. The state uses a weekly infection ratio, WIPR, which is the total number of COVID-19 cases reported in the week multiplied by 1,000, divided by the total population of the ward for imposing restrictions. And we are looking forward. Is there any modifications or change required? Also on the occupancy restrictions. Another point is the vaccination strategy. As I have just mentioned, we could cover more than 73% of the total population above the age of 18 years with first dose vaccine. And also we have conducted special campaigns. And it's found that the Delta variant is spreading the disease in second wave in the state. Do we have to focus particularly on anything, or any change in strategy is required at this point of time? Another point I would like to bring to your attention is the testing strategies. The testing strategy that the state has adopted is a real-time polymerase chain reaction of all symptomatic cases and rapid antigen test in surveillance and random mode. Those with comorbidities and severe symptoms are managed in hospitals. The fifth point is on genome sequencing. We are sending samples from vulnerable groups for genome sequencing. And what are the priority groups in whom a regular genome sequencing has to be done to detect emergence of any potential new virus variant. And the other point, which is already mentioned, is the opening up of schools and colleges. The country has not yet started vaccinating children. What all are the risks involved in opening the academic institutions, especially schools, at this point of time? Your overall strategic input will definitely assist us in strengthening our response to the pandemic. I wish all success to the deliberations. Thank you.
Honorable Chief Minister, Health Minister, and experts from outside India, within India and Kerala, senior officials, and my dear friends, good evening. We are indeed extremely pleased that large number of erudite scholars and experts are here to advise the government of Kerala to refine further and make necessary modifications of our COVID control strategies. Kerala has fairly well managed the COVID pandemic. I'm extremely happy to say that number of experts who are participating in the webinar here have written and talked about Kerala's effective management of COVID control. I was just reading the article by Dr. Giridhar Babu that appeared in the Wire, and Dr. Gangadeep Kang has gone on record admiring Kerala's achievements, and Dr. Jacob John is very frequently writing about the challenges faced by the Kerala, as well as how we are effectively managing the problem. But it may appear a bit ironical that our success in the management of the first wave has thrown up a lot of challenges in the second wave, because our zero prevalence rate is very low because of our effective COVID control in the first stage, as evidenced by the prevalence study by ICMR. And therefore, we are facing a highly infective Delta virus in the second wave with a very low zero prevalence rate, with a high morbid a susceptible population. Our density of population is very high, and our population demography, if you look, it is almost on par with that of developed countries. It's a highly morbid state as well. Nevertheless, we are very happy to say that the surge in the second wave, the public health system was never overwhelmed by the increasing number of cases. In fact, we have achieved what is usually described as the flattening of the curve very successfully, and the mortality rate is as low as 0.5%. However, we feel that some of the control strategies we are following need further modification, refinement, and course correction. We are not in a self-congratulatory mode. We are feeling that we need some change here and there. We have already listed about 6 of them. We would like to get your views and suggestions. These include, as enumerated by the Honorable Health Minister, testing, vaccination, genomic sequencing, issues related to school opening, mobility and occupancy restrictions. However, I may say that you may also bring other issues that need to be considered related to COVID control management. There are a large number of new issues that have come up. When such a webinar with a number of very erudite scholars is organized, there is naturally a time constraint. But we have to make it clear at the outset that this is not a closed webinar. It is not an end in itself. Rather, the beginning of a continuing consultation with the experts till the COVID is fully under control. We would like to continue our deliberations with you in the immediate future, according to your convenience, where more elaborate discussion can be done on specific issues. We hope to arrange a few focus group discussions in future. Now, as far as the house management is concerned, I may bring to your attention that we have about 20 experts from outside India, within India and from Kerala. These are the designated speakers. And we request you to confine your responses to 6 to 8 minutes. It is very embarrassing for me to say this, but nevertheless, we have to manage the time which is available with us. And this will be followed by comments by experts for 2 to 3 minutes. There can be, if time permits, we can have a question and answer session with the experts. That is how this is going to be managed. This is a 2.5 hour webinar. So with these few words of introduction, may I call upon Dr. Bharat Panghania, who is the Senior Clinical Lecturer, University of Exeter Medical School, for his initial remarks. Thank you very much.
Namaskar, everyone. Namaskar from Bath in England. And it is my pleasure to address Chief Minister Kerala and all my lovely colleagues here together. It's a pleasure to help. So what I wanted to share with you is I have been an infectious disease consultant in communicable disease control for over 30 years. And this is very much my bread and butter. This is something we have done every day, all the time, albeit on a small scale. Nothing is different. Nothing is different on a larger scale. So my opening remarks to everyone, all my colleagues and our Chief Minister and my erudite colleagues here is we must keep it simple. We must keep it simple and we must remain focused on what the major issues are. We cannot deal with all the issues, but we can deal with major issues first. And the biggest important point not to let out of our sight is that this is a person-to-person spread of infection, mostly aerosol. So with that line, that strap line in front of us, always in front of us, which is aerosol spread, person to person, human to human, we bring in our control measures and do our best. The other point I really wanted to emphasize and mention is that what works in India may not work in Kerala. What works in the United Kingdom, the United States, European Union may not work in Kerala. And therefore, our preventative protective measures must be Kerala focused. And with the word Kerala focused, whilst we cannot address all the issues here right now in this webinar, as Dr. Iqbal clearly articulated, we need a smaller group with which to take forward the strategy of how do we get above the SARS-CoV-2 infections and the COVID-19 pandemic. So my advice first and foremost is that we accept that this is aerosol spread, and then we bring in our preventative measures. Prevention is the key. Unless and until we prevent, everything else is firefighting. We haven't got the resources to firefight. And therefore, we have a big strategy of prevention. How are we going to do the prevention? The biggest way of preventing it is to look at the very simple routes of transmission. The routes of transmission are when people get together. So this is on buses, trains, social gatherings, weddings, funerals, schools, businesses, crowded shopping centers. Those are the places where people get infected. And there is very little we can do to stop this infection unless we take the thought, which is aerosol spread. Now, I am a fellow Indian and I know how Indians behave. And a lot of it is about educating people that in the short term, you are going to have restrictions. And wearing good quality masks is what I'm coming on to now, is a worthwhile investment. Wearing a better quality mask, especially in the red areas. What I mean by red areas is danger zones, will mitigate, will reduce the spread of infection. A better quality mask is not a flimsy piece of cloth. A better quality mask I'm referring to is a FFP2 type of mask. it is an investment worthwhile making in those danger zones. The second point, again in the danger zones, is increasing ventilation. So increasing ventilation in closed indoor spaces will prevent the generation of cases. The third strategy is you run at full pace to immunize. Even a one-dose vaccine is better than no vaccine. So you must immunize your population, starting with the vulnerable, the older age group, people with diabetes, other comorbidities. You identify your at-risk people and immunize. And I'm pleased to hear that your immunization program compared to the rest of India is already very good. So you really need, in terms of protection, to immunize, because if you protect your population, they don't end up in hospital, they don't end up on the ventilator, they don't end up dying. So the first strategy is prevention. The second strategy is immunization and prevention. The third strategy that I would advise is that you do a lot of forward planning, because we do not know at which stage where the variants may arise or a new wave may arise and may overwhelm the hospitals. The hospitals need to be in a prepared state, or you need to also set up facilities for field hospitals, whereby there is economy of scale, managing all the people together in one setting as an emergency disaster management issue. And finally, what I want to say is, if possible, we need to set up a small group looking at all those smaller details which were in the briefing paper, and we address them line by line and more. And I hope if such a thing is set up, I would be very happy and prepared to give off my time and energies to make it better for Kerala. So I will stop there, and hopefully my other colleagues will also contribute to the way forward. Thank you.
Thank you, Dr. Bharat Pankania, for your encouraging words, especially your suggestion towards forward planning. That's a term which has not been used so far. We will look into it. Thank you very much, especially for sticking on to the time as well. Now we have next speaker is Dr. David Peters from Johns Hopkins University. He is with the Edgar Berman Chair in International Health. Dr. David Peters.
Thank you very much, Honorable Chief Minister, Honorable Minister of Health, and every one of you in this very impressive group that's here today. It is an honor to be with you. Let me first congratulate the state and the officials in Kerala for how you've responded to the pandemic so far, and for your forward thinking about looking to medium and long-term implications. I'd like to start with some general comments on the potential future of COVID and therefore its implications for our strategy over the medium and long term, and then deal a little bit more specifically with some of the vaccine strategies and testing, for particularly around continued vaccine effectiveness monitoring, and then around schools as one of the examples as well. So I think the first point I would like to make is that we should be considering this as the beginning of a COVID pandemic era, rather than just seeing this as in the phase of another wave and a long tail of an epidemic, or an evolution to an endemic disease that has some regular recurrence. And the Nature paper that was distributed was very nice there. It has very sophisticated models, which I would consider a baseline case. And what I'd like to propose is that we also think of this as a new era, much the way the 1918 influenza H1N1 pandemic really introduced an era of epidemics and pandemics that continues for more than 100 years. This is because it's a result of genetic mixing, both within bird, swine, and human viruses, a lot of gene segment evolution in multiple species, and with response to selection pressures, immunization, herd immunity in different populations over time. And waning immunity suggests a regular COVID season, but the other changes suggest potential for recurrent epidemics. And I think there's a strong possibility, given how we've seen so much genetic evolution already, that such interactions, particularly because of the relationship to other animal viruses with COVID, will over the next years produce periodic epidemics and pandemics in addition to what you're seeing. One implication is that we need to be fully prepared for future pandemics and epidemics with systems and capacity building for the medium term. So we need a long-term game plan and not just the immediate one, which is what we're just coming through. It also means you have to think about which interventions you can sustain and which interventions you can come back to. One of the things that will help is monitoring vaccine effectiveness against different variants, certainly in different populations that we've heard about, immunocompromised in particular, the elderly, but also over time to see how long immunity lasts. And I'd say also increasingly looking at 1-dose versus 2-dose strategy. As we've seen, a 1-dose versus 2-dose and the potential for later boosters need to be driven by data. The current data just published shows that that for the Delta variant, a 2-dose strategy is really needed, whereas a 1-dose strategy, trying to get everyone covered with 1 dose, was more effective against Alpha variant. The 2-dose strategy, which has less effectiveness from the first dose, really means we need to push for that 2nd dose. And of course, continued genomic sequencing. I think a lot could be done on the model that can help that, particularly looking at severe disease, but I'll skip that for now and then move on to the implications for the kinds of restrictions that are proposed as options. A lot of these restrictions might become a huge problem over time in the medium term, both politically and socially, as well as economically. There's a good rationale for many of them, but there's not a lot of specific evidence around about many of the particular interventions, such as around movement and closures. I mean, it's likely that multiple interventions done together help early in the epidemic, much more difficult in terms of learning how to lift and put them on and off again. Some of the implications involve, one, continued need for community engagement, assessing acceptance of intervention and costs and consequences. I think shop closures, movement restrictions, gatherings are different from masks and hand washings and vaccine acceptance. So you need to continue on that. I'd also say a particular focus on potential super spreading events from mass gatherings, festivals, holidays, and the like. I'd say we also need some specific principles around decisions for different settings that are based on risks. And perhaps this is already done, but getting some principles that would help with communicating interventions and why you're changing them. So I would suggest comprehensive risk assessments around the kinds of interventions based on epidemiology, which are largely about risk of transmission and severe illness, the economic risks and the social risks, mental illness, well-being, safety nets, harm to other programs, and other unintended social political consequences. In terms of epidemiologic risk, I think it's clear you want to look at particular populations as well as things like contact intensity, number of contacts, and potential for modification. And you can do this in a structured way. For example, schools. So this is the last example I want to come to. School closure can't continue indefinitely, and it's unlikely to be inequitable and a stopgap measure if you continue in an online mode. But you can look at particular settings, whether it is childcare, elementary school, and as you get older into the ages in which people can be vaccinated, look at what kind of contact intensity, high to low, what kind of number of contacts, and potential modifications potential. So the kinds of interventions, beside closing things and going to online alone, which is not very tenable in the long term, for many reasons. What we're finding is that, first of all, a mandate double vaccination for all staff and anyone over the lowest age limit for vaccination. Mandatory masks as long as there's a high prevalence, and of course, hand washing. De-densification and cohorting as students. I mean, distancing is fine, but often you have to consider shifts in putting alternate weeks or scheduling around those type of things. Daily screening for symptom screening for all, and that all unvaccinated people, students, you want to be able to test them twice a week just saliva-based PCR testing would be fine. And of course, anyone with symptoms, you need to be able to stay at home and then follow up with contact tracing. So contact tracing is tough at most times, but this is an area around schools where you should focus on contact tracing and regularly, I would say twice a week, but the minimum once a week testing, along with mandated vaccinations. So I think I would also agree with the overall comments previously made about the need for continued planning and looking at each of the interventions. Again, I would suggest putting each of them in a structure around a comprehensive risk assessment, which goes beyond just the epidemiology. And I would be happy to participate as best I can to your efforts. And thank you for the opportunity.
David Peter's core messages was there are that he's expecting we have to expect a pandemic era. The humanity has to expect entering into a pandemic era with the possibility of a influenza virus emerging with a new variant with genetic mixing of avian and human viruses. This has already been predicted. But I think what the most important message he has said, the core message I would say is that we should indulge in a comprehensive risk assessment strategy. A comprehensive risk assessment, epidemiological, economic and social risk assessment strategy need to be followed. Thank you very much, and we will keep in touch with you. I may now call upon Dr. Patrick Osevi, who is the Chief of the Asian Development Bank Health Sector Group. Dr. Patrick Osevi. In case he is not here or not getting connected, I may call upon the next speaker. We can always come back to Patrick later. I am extremely happy to invite Dr. Devi Sridhar from Scotland, because the other day I was reading Gavin Francis' book on intensive care. Gavin Francis wrote his experience for the first wave of COVID in Scotland. So we were very much impressed by this. In fact, I have written a review of this book. So she's in the chair of Global Public Health at the University of Edinburgh and advisor to the First Minister of Scotland. So Devi Sridhar.
Great, thank you. And first of all, congratulations on your success in containing SARS-CoV-2, not just the first wave, but also the Delta wave. And we have been learning from you, I would say, here in Scotland and following what you've been doing and building to try to learn across countries. The second thing I wanted to say is in Scotland, we have also been looking at moving from maximum suppression and containment to a more sustainable exit of how do we live, if we don't say live with COVID, but actually manage this in a way that means we can open up and address the other harms that have accrued because of restrictions. So I really just wanted to make 4 points that I hope are helpful based on the Scottish experience. The first is with Delta, that we have, because we have very good sequencing and electronic health records, been able to tell the differences between the wild type, Alpha, and Delta. And what we have found with Delta is that people can be fully vaccinated and still test positive for COVID. Most likely they have a mild illness, but this is different to the wild type where we found that vaccines stopped transmission. So now Delta seems to be able to transmit. And what has this meant is a move away just from case numbers to understanding behind the case numbers, what are we seeing? Is this vaccinated people who have mild illness? Is this unvaccinated people? How many end up in hospital? How many have prolonged illness? So instead before, when we focused on incidence per 100,000 as being the main metric for restrictions, there's now more nuance. And actually, what do the case numbers alone matter, or what are they telling us? To give you an idea of our vaccination rates, first vaccines have been given to 90% of the adult population, second doses to 80%. And now there is a large push to try to get more doses into those younger people, because it's largely people, I would say 16 to 30 who are waiting on their second doses. The numbers for first and second doses fully vaccinated over 50 is over 90%, 95%. So the second thing is one of the metrics we're looking at is case conversion. So how many cases translate into hospitalizations? Because the worry, I guess, similar to what you were saying about flattening the curve, is staying within hospital capacity and bringing down the case conversion. So when the virus first emerged in Wuhan, I think Chinese authorities, WHO said 20% was the case conversion. Then this moved down with larger testing for asymptomatic cases to about 10%. And now in Scotland, we're finding that it's around 3 to 4% with vaccinations. But this still isn't good enough if we see an escalating epidemic, because absolute numbers go up. And so part of that has been looking at how do we get that case conversion lower? How many of those cases in hospital can be prevented by going into hospital because they're vaccinated? And how many are in hospital because they are doubly vaccinated, but they're frail? The vaccines are not 100%. So there are people in hospital who are doubly vaccinated, largely those over 70 and 80. So it tells you how much of the problem you can solve with vaccines and how much in a way you can't. So the third thing I want to mention is schools, because the past year I've been on the schools committee. So schools shut in March 2020 in Scotland, and they stayed shut through the summer, but they went back in August 2020 for in-person learning and were largely open for much of the year. The mitigations put in place were a large push to have outdoor learning, windows open for ventilation, bubbles, so kids were held in a bubble of 30 or 40 so that if there was a case, the whole bubble would have to isolate for 10 days, as well as trying to get testing as that availability became apparent. The main challenge we found in schools was actually teaching teachers and unions who felt it was unsafe that they might contract the virus in the school and didn't want to work. So now the big push is on teachers being vaccinated, and teachers are happy now to go into classrooms because they feel like they're fully protected. And most of the teaching age is actually younger. Teachers are generally in the younger age group that we found here. And so I guess now schools are back in Scotland. They've just gone back pretty normally. And the big change has been, first of all, the bubble system has been changed, that if now someone tests positive, all the other kids in that bubble get tested, but if they test negative, they can go back to school. And the reason is otherwise there's continued disruption. The expectation is that there will be cases in children. I think that's inevitable. But what pediatricians are telling us is they're less worried about COVID in children than they're worried about the other harms of kids being out of school, mental health issues, and that largely the children that we need to be looking at as protecting are those who are either at higher risk because of comorbidities, and the other issue is obesity being a big risk factor for hospitalization. And I do want to mention that I think as quickly as possible as you can get schools back to in-person learning, that actually the impact probably will be smaller than you think in terms of the increase in transmission from the school environment itself. What we have found is schools going back is less about the schools in the classroom. It's more about the environment, such as parents going back to work, greater use of public transport, greater use of shops, services, the back to normal message of just go back, get back to life. And so here we needed to give a message to parents, which is stay away from the school gates, drop your child and go. If your child is ill, don't send them into classes. Get tested if you think there's any reason your child is unwell, as well as having home testing. So we have these lateral flow tests, which you could take home and people can test themselves to try to pick up infections. The last thing I wanted to mention is around tourism, because I read in the paper that Kerala is a big tourist destination. It's a big part of your economy. I have visited Kerala for tourist reasons as well in the past. And what I would say is that the way in Scotland that tourism has just tried to be opened, we've just had festival season, is through requiring people who enter to be doubly vaccinated and to show that upon entry, as well as to have a negative PCR test. And the idea that is if you have people who are doubly vaccinated and have a negative PCR test, the chance of transmission is much lower. It is not zero, but the worry was that keeping tourism shut for much longer has a cost in terms of jobs and in terms of livelihoods. And so hopefully that's helpful to your thinking of how we manage this transition going forward. Thank you.
Thanks a lot, because we will actually we are also concerned about the Delta virus partial vaccine escape. We are already witnessing that with a large number of positivity among the vaccinated. And also we will look into this bubble system and also its limitations and advantages. And one thing which you have pointed out that apart from COVID, we should also look into the mental health of the children. That also will look. And being a major tourist spot, the other points you raised about tourism also will be looked into. Thank you very much. Thank you. Thanks a lot. Now, may I call upon Dr. Ajay Mahal, who is from Melbourne, Australia. Australia is one country which has fairly well managed COVID, even in the initial stage. He is the Professor of Health Economics and Global Health Systems Research at the University of Melbourne. Ajay Mahal.
Good afternoon, good morning, I suppose, wherever you are. And thank you, the Government of Kerala and the Honorable Chief Minister for having me at this meeting. I think a lot of the points that I would have liked to make have already been made. So let me focus on an area where I think as an economist, I could probably make a few observations. I speak today from Melbourne, where when I heard the equivalent of the Chief Minister in Melbourne, it was a defeated voice. The idea that today, for the first time, Melbourne had a 3-digit 120 new cases of COVID, and there is an expectation that in the next few weeks, the numbers are going to rise sharply. And I think two sorts of issues have basically come up. One is around incentives, that there is only so much one can do in terms of forcing very hard lockdowns and restricting people. Ultimately, economic incentives, jobs, schooling, mental health, as both David and Devi mentioned, are going to play a big part in individuals and households' decisions about how they might react to policies. So I think you can't run a dictatorship in a democratic society. I think that's going to be always the challenge of how do you sort of make people's behaviors align to the incentives of society as a whole. And at some point, the costs of lockdowns are going to, in fact, bite very sharply. And what I thought was that, why is that arising? I thought I'll put up a bunch of slides for you to just share with you some data. And the reason I'm putting this up is because I think the sort of issues that were raised in the discussion paper led me to think that actually these are all difficult choices, and there is evidence on both sides of these kinds of questions. And without good data, David called it risk assessment in his earlier talk, it's very hard to make these choices. You'll have to come down on one side or the other. But I think I would have, in Australia, for example, we do a lot of heavy duty modeling almost every day. The modeling is done and new results offered. And essentially the Chief Minister has options literally every day as to which way to go. So what I thought was I'll just highlight a few issues around schooling and youth concerns in Australia. And if you don't mind, I'll just share my screen. And so what I have here is actually some data from recent surveys where last year, this is the most recent available. The top 3 concerns among youth in Australia, 15 to 19, in the survey done last year. 1, education. 2, mental health. And 3rd, COVID-19. And even that, when they dug deeper, they found education and mental health, again, were a major source of concern. So I think if that's a concern, then one has to address it. Otherwise, all these strict lockdowns are not going to work. The other issue, which the Honorable Chief Minister mentioned, I think is an important one, the issue of long-term effects. It's well known that success in the early part of your job career has long-term implications on future success. And so what we are seeing in Australia, for example, is if you have any separation from education or employment opportunities, there will be long-term effects. So here is some data again from Australia. This is for the last 3 years. There are these three charts, these three bars. One is for May 2019, one is for May 2020, and one is for Feb 2021. And what you see is that immediately following the lockdown, which happened in early part of last year, basically the proportion of youth not in education or employment jumped up by 50%, not percentage points, from 8.7 to 12, or well, 40%, I should say. It went down a little bit because Australia instituted a whole bunch of programs to keep youth in jobs through something called the Job Seeker program. But the key point here is that, again, economic downturns can have long-term implications for the well-being of young people and their future careers. And that's going to play a strong role, not only in terms of the economic well-being of Kerala in the long run, but also in terms of their incentives to react in a way that can address the concerns of the government regarding the COVID situation. Finally, some data from India. We did a telephone survey of households in UP and Odisha, and these are mainly poor households. And what you see actually, I mean, and this is basically, this is the orange one, I think, is Odisha, the blue one is UP. And what you see here is during lockdowns, a very large proportion of households reported their kids being unable to attend any sort of schooling. Online education is not easy. Not everybody has access to smartphones and internet connections. I mean, I have problems in Australia. Forget about rural India. So at some level, despite Kerala's very advanced state of affairs, infrastructure, and so forth, I think these are challenges which will have long-term effects, and if not just for the state, but also for the individuals and households concerned. So all I would say is that I think the risk assessment exercise has to consider these sorts of challenges, but the way you can do this is what I would say, you certainly need more data, a better assessment of what the costs and benefits are of alternative courses of action. And I'll simply stop here because I thought that already a whole set of very lovely points have been made by previous speakers. Thank you very much again for the invitation.
Very, very thought-provoking intervention. It was good that there is a health economist is here in the midst of largely medical experts, because any pandemic for that matter is not only a medical problem, it has got tremendous socio-economic impact. That is what he was referring to. To lockdown or not lockdown has been a persistent question of debate even in Kerala. And he also mentioned about mental health issue. I think we have not given adequate importance to mental health issues. Devi Sridhar was also referring to this. We will look into these aspects a little more closely. Thank you very much. We would like to continue to interact with you also. May I now call upon Dr. Sangsupra, Chair of the Education Sector Group in ADB, Asian Development Bank. Yeah, I hope I have pronounced your name properly.
Thank you, Dr. Iqbal, for a kind introduction. It's excellent pronunciation. So I'm sitting in Korea. I'm very happy to join and privileged to also join this meeting. I visited Kerala a few years back, associated with the ASAP, the Kerala the Additional Skill Acquisition Program. That was the known as very innovative project, and that project, I think, the replicated in other states also. So I see the Kerala is the state which produced a lot of innovative approach in education. I know in the health sector, also Kerala is one of the advanced states. So I am privileged to have this opportunity, share my view in the presence of the Honorable Chief Minister and also Honorable Health Minister, and also Honorable Chief Secretary, also Honorable former also Chief Secretary Dr. Ram. As an education specialist, I really like it. Professor David and other professor all advocate the importance of reopening school. I really support that because you asked whether Kerala considered to reopening school. Yes, there are, I would say, around 4 to 5 reasons, but already all the distinguished the speakers already mentioned the reasons. So, but I like to make it very brief. First, why we have to reopen school? Number one, that the evidence from Scotland, we hear a while ago. Australia, we also heard it. Germany, Italy, and Korea, and US shows that school closure appear to have it limited it or no effect on the COVID-19 instance. I know here there are a lot of health experts here. You might have a different view, but there are evidence and the study on that. Of course, this needs to be further tested in light of the Delta variant. So why is that? Why the closing school has limited or no impact on the COVID-19 prevention? Because simply is this, even if a student do not go to school, it doesn't mean that they stay at home. And a student cannot go to school, what they're going to do, they will go and meet the friends, and also at the friend's house, or they go to playground. So chance that without even wearing masks at home, also in the playground. So therefore, chance that they get the COVID when they go to school is even higher, I would say. In fact, before I coming here, I talked to Korea Ministry of Health, and the Ministry of Education, the senior officials, and then ask about this. They think school is safer than even home. Because students, they follow the hygienic hygiene protocol better than the adults. Second one, already other colleagues, distinguished panelists already mentioned that lost school time caused the permanent damage to children in both the near and the longer term. That's a serious, that's negative consequence on the labor income, and also health behaviors, and the marriage, even fertility and mortality, many things. And also intergenerational impact on the human capital. So this is quite serious. We did some study, ADB, on the India cases, also South Asia. I think the learning loss in the South Asia, I think is old data, but about 3 times of the East Asia. This is quite serious. Third one, since we have so many here, the distinguished medical doctors here, I argue that children are less likely to be infected by COVID-19. There are a lot of also study. So first one also from the inequality aspect, children much less likely to be infected. The school closure will intensify inequality. Particularly students from the low socio-economic background, they were much more affected by this. Now, one of the questions I saw is that how to really reopen. I have a couple of the recommendations. Before going in that, I already found the Ministry of Education, Indian government issued the standard operation procedure SOP in the October 2020 for reopening of the school. I found this is very comprehensive, really well prepared. I think the Kerala government may wish to consider adopted a lot of elements from this SOP. For example, only 50% students will be allowed to attend classes in each session. I think this is a good one. It can be not only 50, it depends upon the situation. It can be 1/3 or 2/3. It can be very flexible, depending upon the local context. I found also very interesting also recommendation from there. Attendance of a student will not be enforced, and then will be entirely depend upon parents' consent. I found India, this policy really gives a lot of flexibility to the school and administrator. In the case of Korea, in many countries, once school decided this is mandatory because they will track the student the attendance. But Indian one, I think this one, I think very flexible because some parents may not be comfortable in such cases. I think this SOP also said in case student cannot attend, a school provided online class to them. Also, that's very wise also advice. Also in school, the wearing of the masks is a mandatory. I think it's a very good one. And also students have to follow very stringent hygiene routine. Also, this is very good. Also, I found a lot of protocol on the lunch time, also breaks. These are all well prepared. Now I have one thing to try to here. On the top of this, I want to read all in the SOP, but I want to pick up from the experience from the other countries that training should be given to the student as well as teacher and all school administrator before you do it, so that they can really follow the hygiene protocol. And then also another one I would say, I think some experts also mentioned about vaccination. I think in the case of Korea, the all teacher and also school administration, they were all vaccinated before we reopened the school. So I think that you may wish to also consider that the vaccinate all teachers and the school administration people before you reopening school. That give them also comfort, also the comfort to the also parents and also students. Also, it's very important to also engaging parents and other stakeholders, because Kerala, in the case of Korea, I think the teacher labor union was uncomfortable. So it's very, very important. Also, some parents were not comfortable, but it's extremely important to so they engage. Importance of the bring the student to the school. Because of many reasons, mental issue, social behavior, all kinds of issue. And then also I found India as the beginning of until the beginning of the August, about the 17 states already started reopen the school and then plan to reopen school. Well, perhaps more there's a state already doing that. But here I found very interesting, like Tamil Nadu and also the even Gujarat, some advanced state, they prioritize the secondary and higher secondary student when they consider reopening the school. But I feel this is a bit odd. That because perhaps they need sitting for the board exam. That for the education purpose, I thought I think we need to reconsider. I believe it's very important to open for the grade 1 to all the way to grade 12. Particularly focus on grade 1 and 2. Why? Foundation skill is extremely important. And then grade 1 and 2, that student, they don't have ability to really adapt it in online learning mode. And then also going school is extremely important for so that they can learn the social interaction, all kind of things. And then the interact with the teacher for them is really important. And also, this is important to reduce parental childcare burden also. So given this, I thought that bottom-up approach is very important. The grade 1 and 2, if possible, also the preschool student, you may wish to consider. And then, but if possible, of course, because the board exam also equally important to you for the many parents. So I suggested consider opening not just only high school student, also the grade 1 and 2 small children also. Also, I noticed the infrastructure issue. It's very important to provide it. I think the professor already brought the Bankani mentioned about high quality mask issue. This is important. Invest it for the school so that they can have it sufficient and also good quality of the masks for those children, and also the teacher, so that they can be comfortable, and also prepare the sanitizer so that they can even wash their hands before coming to school. Now, the last one is that I'm thinking about the post-COVID, even the when prolonged COVID issue. In such cases, we have to think about hybrid learning. Then we have to really give a good training for the teacher and school administration so that they can maneuver in the new world very confidently, so that they can really take care of the children very well. I know, despite a lot of challenges, teachers in Kerala, they're working really hard, to reach out children and then provide education. They are delivering even print out material to the student whom do not have it online internet. But you have all those good people, but I think with the support, this kind of support, I think they can be more effective. Thank you very much.
Thank you, Dr. Suprad. And he was focusing on school education. We are yet to look at it. Kerala has not decided to reopen the schools. You have made a major comment that we should rather start with the lower classes rather than the higher classes to reopen. We will consider your suggestions when we work up for school reopening. Now, our next speaker is Dr. David Wilson from the World Bank. He is the team leader of COVID-19 of World Bank.
Thank you very much indeed. My comments echo those of other speakers, and I will make 4 points. First, as other colleagues have said, we are on a pathway of managed endemicity in this pandemic, and this coronavirus will join the 4 other commonly circulating coronaviruses which we have learned to live with. But we need to manage the endemicity to minimize risk and illness. And as other speakers have said, we can do that. My second point echoes earlier colleagues and is a plea for better masks. In the US, either KN95 or KN94 or their global equivalents. Like other speakers, I believe these are a very good investment. Like other speakers, I would like to commend Kerala for its vaccination program and urge increased attention towards the most vulnerable, the elderly, the comorbid, the immunosuppressed, to reduce the case conversion rate. Because in a world of managed endemicity, we are focusing, as Devi has said, on case conversion, not on cases per se. And my final point is to continue to improve our therapeutics and COVID management through proven approaches such as dexamethasone, oxygen, and other promising approaches. And I think this represents the best possible pathway towards managed endemicity, with vaccinations helping to defang but not completely eliminate the virus, and masks and better care enabling us to move towards managed endemicity at less cost to society. Thank you.
Thank you very much. This was a very short but very effective, pointed suggestions that has been given by David Wilson. Thank you very much. Now let us move on to Dr. Kangetkar, who is the former head epidemiology ICMR.
Just 1 second, sir.
Sir.
Yeah. Sir, I'm going to perhaps present a different viewpoint. No, I know Kerala has done really well, and I'm really grateful that I was invited for this particular meeting. But there are some thought-provoking statements that I would like to make. We need to distinguish at this point in time of this phase of pandemic that initial measures that we had adopted were mainly because we had no vaccine and we had to handle a droplet infection that was spreading rapidly. So we had non-pharmacological interventions, including lockdown, which were used to reduce the risk. Now that you have additional vaccine that comes as one intervention, we need to remember that there has to be a change in the strategy, given the fact when there was no vaccine, we could not ensure that the infection does not get established in our country. And now that infection is there, we also have vaccine, and we know that vaccines are protective against hospitalization and death, but not against infection. So what are certain implications of these statements? You know, the daily new infections are likely to increase dramatically over a short period of time as our vaccination drive continues to ensure that the coverage increases. Perhaps what is required then is to monitor hospitalization, monitor deaths, and give lower priority to new infections, because there will come a stage where perhaps you will find that even a small state, let's say even Kerala, if it reports huge number of infections, it should not cause much of a botheration because hospitals may continue to remain vacant. You will be able to extent if we vaccinate majority of the population. Symptomatic reinfections continue to be very low. Now, the implication is perhaps whatever is being talked of with respect to the mutations, with respect to the infections that tend to occur despite vaccination, there is still a reassurance that symptomatic reinfections continue to be low. So health impact is likely to be lower once we start vaccinating, once we complete our vaccines as such. Vaccine plus mild infection, perhaps that's one approach that we may be seeing over a period of time, because we know that since reinfections are low, what is important is vaccines will not prevent mild infections, but mild infections will perhaps also act as a booster to the vaccine that has been given. It may eventually go towards focal outbreaks among unvaccinated, vulnerable population, let's say 45 plus, chronic morbidity, and those who are immunosuppressed, and eventually go to endemicity. Now, what are the implications? No, one worry that we have is about variants. Currently, Delta variant continues to predominate across the world. Now, what is important is there is a new talk about 1.2 there is so high that perhaps it is not stable. It doesn't give you the same fitness to this particular variant to predominate. We may have to wait for some time to make robust statements based on the evidences per se. So how do you monitor to strategize in absence of effective vaccine? No, whether we should go to prior strategy, if you have solution in the non-pharmacological interventions plus vaccines, perhaps a new variant has to come. But we would like to detect the new variant very early. Now, how do we do that? For early detection, we need to test the symptomatic breakthrough infections more often, test the cluster usual partners, and try to include them into genomic surveillance, which will be far more useful to find out new variant that emerges. What is also important for us to recognize at this juncture or consider that testing all those who have mild symptoms, perhaps is not going to be an effective strategy. We may waste not only money, but the time of healthcare sector unnecessarily, because if you have high vaccine coverage, asymptomatic and mild infections are going to increase, and numbers essentially just don't matter. What we perhaps have to look forward to is to test only those who are symptomatic or those who get hospitalized, because that's the way we have been following, whether it is influenza or whatever. Eventually when it comes to respiratory infections, where majority of the infections that occur are likely to be asymptomatic. When it comes to school testing, one of the things which I would say is monitoring is going to be extremely critical. In addition to the earlier strategies that have been spelled out, I would suggest that pool testing could be done, as ICMR had prescribed earlier, to monitor infection in the schools wherever the prevalence of the incidence of new infections is low in the community. That might help us in ensuring that the strategy works of school opening really well. When it comes to isolation, which was one of, there are some things which we have to keep at the back of mind. We need to recognize that with the emergence of new and newer variants, what is going to be this with the new and newer variants that tend to come, which was also which may lead to shorter incubation period, and that has been reflected really well in Delta variant that we had observed. Now, whatever non-pharmacological interventions that we had been using, whether it is isolation or the COVID appropriate behavior, they are likely to lose its efficacy. And therefore, what is important is perhaps then we may have strategizing what we could be doing. It could be reverse isolation, shifting the unvaccinated or vulnerable people above 45 plus. If you find infection in a household, perhaps you may be able to ensure that he or she may remain protected better. And the second thing which we have to realize why this will become a crucial issue, because we need to remember, even if you have a good, effective, let's say a mask, it is not only that. We must remember that by one of the critical things which will decide on effectiveness of use of mask is the shorter duration that tends to occur as unprotected exposure that might be seen, because the person may not adhere to those behaviors and they may still end up into having infection per se. So essentially, my contention is we may have to think in terms of looking at an alternate strategy because vaccines are available and vaccination trying to protect as many as possible by ensuring will continue to protect us for some time. If you look at MERS data, where it was done only in about 21 people who had MERS infection, they found that despite the fact that they were tested right up to 6 years, they continued to have presence of antibodies that they could generate during experimentation, and therefore you could stimulate them. So essentially my gut feel is this infection will follow one pattern. If we vaccinate all, mild infections will increase, hospitalizations will decline, and slowly we will move towards focal outbreaks and endemicity. Thank you.
Thanks a lot, sir, for your very unconventional views. But these are some of the things which are being discussed in our circles also. What you essentially says is that even when you vaccinate because of partial immune escape, there will be infections in the community, the breakthrough infections and post-vaccination infections. These are mild infections and we need not be worried about that. And we need not be worried about the increasing number of positive cases because of the post-vaccination infections. That is essentially your message. And also you also went to the extent of suggesting that we need not test all the mildly symptomatic cases. That also we have suggested. These are points which we are debating in Kerala. Thanks a lot. And such words coming from such a senior professional like you will carry a lot of message to the community and also to the media. Thanks a lot, sir. Now, next is Dr. Anurag Agarwal from IGIB, CSIR. We are very much closely associated with IGIB. We are very thankful to you. You are doing the whole genome sequencing for Kerala from the very beginning. We are very continuously in touch with your experts like Vinod Skaria, who happens to be from Kerala also. So we are very happy, sir.
Thank you, sir. It's been a pleasure to work with Kerala in making it one of the most well-sequenced states in the country, for which we have the most genomic information. I'll briefly speak on how we use this information to perhaps make a few suggestions and why evolution of the virus means that perhaps our measures must also evolve. As you are well aware, the Delta wave has been driving the second wave in India, arrived slightly later in Kerala compared to North India, has been running longer, which itself sometimes is a testimony to control, but creates a new set of challenges, which David said very correctly, as managed endemicity. So what would managed endemicity look in a time of Delta? What is unique about Delta is that it has very, very effective transmission, even breaks through relative, half implemented measures like half masks, because the viral load is much, much higher. Immune escape is significant. If you look at single vaccinated population, the protection is barely 30% or so in terms of being able to protect against infection. What it means is that in absence of increased severity, but very high transmission, we are looking at a scenario where in most places, it continues until immunity causes it to burn out. That immunity can be natural. If it is acquired, it's going to be at least double vaccination. It will not be single vaccination. And the management will be of three types. One is controlling the rate of transmission, so the total number of sick people presenting to hospitals remains a manageable number. The second part of management is that high-risk populations quickly get double vaccination because you want to protect them from severe disease. And part number three would be to ensure that at least transmission measures that Dr. Ganga Khetkar, many others talked about, are in place. Regular routine checking to block transmission is perhaps not a practical measure within India. Focusing on physical measures is perhaps as much as we can do, but advocating universal physical measures will simply not work. So we would have to particularly highlight places where transmission is most active, most likely to gather momentum into an exponent that we can't control, become strict over there while relaxing elsewhere. I'll end with only one other point. We should not look only what is beyond our nose. One of the things is this virus has evolved into Delta. It will evolve further. There is no doubt about it. Can we keep this evolution under check? And to that, we must maintain a reasonable amount of transmission, and we must continue sequencing as we are doing already. Already you will see that as you look at microlineages of Delta, particularly AY.4 to AY.23, Kerala, like the rest of the world, is starting to show multiple microlineages come. They're all Delta, but you're also starting to see some of them like AY.1 slowly go from 0.5% to about 2%. We will have to keep a track on it, look at the amount of threat they pose to immunization strategies, and basically continue what we've been doing well, but perhaps at a more pragmatic way in the future. I'll stop here, sir.
Thanks a lot. In fact, we are also looking into this micro lineages issue, and we are regularly in contact with your scientists. Thank you very much. Next in line is Dr. Jacob John. In fact, he is one among us. He is the former retired professor of clinical virology, CMC Value. Sir, Dr. Jacob John, sir. You are mute, sir.
Am I audible now?
Yes, sir.
Yeah, I did not know the sequence of speakers, so I had muted myself. Honorable Chief Minister in absentia, Honorable Health Minister, Chief Secretary, Mr. K.M. Abraham, Dr. Iqbal, and all my friends and colleagues, sisters and brothers, as the Health Minister said. Let me come to Kerala specific issues rather than general issues. Now, Kerala has the most reliable information of any state in India. And today, Kerala's numbers are worrisome. And the problem is an enigma wrapped up in a puzzle. And let me unwrap the puzzle, and I will use 2-3 minutes for that. Firstly, the ratio between RT-PCR and the antigen test reveals that is 1.9 million antigen test and 1.1 million RT-PCR reveals that Kerala is detecting a huge proportion of infection compared to disease. Any infectious disease has infection and disease. And so Kerala is identifying both disease and infection and inflates the actual number that we are all worried about. Why am I saying that we are inflating the number with infections? Not only because of the proportion of RT-PCR and antigen test, but also by case fatality ratio. If case fatality ratio remains 0.5 compared to Tamil Nadu 1.3, Karnataka 1.3, I think we are actually looking at more infections than disease. Be that as it may, these are words of comfort. Kerala has the most reliable numbers because excess mortality, well known in the various states of India, is the least in Kerala. On May 3 of 2020, when ICMR projected 6.46 million infections, Kerala had accurate information on 500 infections, and the remaining 6.4 million were in all other states, undetected, unknown. So Kerala's track record is that we have the best data in Kerala. So for the time being, we have worrisome numbers. And this will pass as your vaccination rate increases, and more people are getting infected. The numbers will begin to come down. When, I cannot predict, but we can say pretty soon. So let's look forward. We need to prioritize economic recovery, educational recovery. And I have some suggestions. First of all, we have 14 districts. Establish district level task forces with the administrative head, the district collector, the district health officer, and all the representatives of the local industry, education, trade, all transport, trucking, put them together in the district and let them grapple with how you can prioritize economic activity and education and avoid social gatherings, religious gatherings, recreational gatherings, and all those kind of things. So that kind of a prioritization is very, very important. The district task forces must make plans for immediate short-term and medium-term, and then get the state's approval for implementing those measures that districts come up with. My final point is that school reopening, I've actually emailed to you a paper that I wrote on the 24th of August, totally agreeing with the suggestion from South Korea that we open up schools from primary classes upwards, because they are the least risk-ridden or risk involved children. But then detailed roadmap are described in my paper that I have shared with you. Scotland also has, like Kerala, a certain increase of numbers, and so have many other countries that had effectively managed the early part of this pandemic. As we flattened the curve of the first wave, we lost the advantage of immunity created by the wild virus, the original virus, the Wuhan virus, which significantly protects against the Delta. And of course, vaccine came a bit late, and Kerala is catching up with vaccination. So with this and the numbers that we are seeing in the 30,000 range during the last 1 week or so, this has a short-term life. It will come down. So Kerala will have to plan to bring into the economic revival and the educational activities as soon as possible. Today, this week is for the planning of it. Let me now shift into medium and long term for Kerala. Kerala deserves a health protection agency for the medium term and long term. Our preoccupation with the COVID will give way to other health problems, and we need to face them. So I would strongly recommend that we think in terms of designing a health protection agency. That is for the medium term, and of course, long term, we can plan in a smaller group. Okay, let me finally conclude by saying that Kerala's test rate is approximately 90,000 people tested out of 100,000 population. It actually is the maximum proportion tested in the whole of the country for any state. We have detected almost 12% of the population already infected. And how many has United States documented? 12%. Okay, so these are words of comfort. Kerala has done well. All we need now is to articulate this in simple terms and inform the public that although people are criticizing Kerala, there are some very important truths hidden in the Kerala scenario that is lost in the spurt of infections that we are all worried about. That spurt is not causing a spurt in deaths. Ultimately, the pandemic management is for preventing death and protecting economy and education. Thank you very much.
Thanks, sir, for unraveling the Kerala enigma wrapped in puzzle, as you put it correctly. And also your optimistic note that this current surge will come down very soon. But one of the major recommendations that is emerging today is that when we reopen school, it should start from the primary level upwards rather than from the high school downwards. That is what is being done in other states. We will look into that and also other suggestions that has been put forward by you. Now the next is Dr. Gagandeep Khan, who is the Professor, Department of Gastrointestinal Sciences at CMC Vellore. We had the opportunity to interact with Dr. Kang earlier also. So now I request her to talk. Hope she is present here. Dr. Gagandeep Khan. If not, we will go to the next person. We can come back to Dr. Kang when she rejoins. Dr. Sanjay Pujari, who is the Director and Chief Consultant of the Institute of Infectious Disease, Pune. Dr. Sanjay Pujari.
Yeah, thank you for having me. It's a honor to be here, and I agree with the observations of most of the speakers, maybe at the cost of reinforcing or repeating. 2-3 important issues I would like to really flag. One is vaccination is going to alter the pandemic. And the way we actually had interventions prior to the vaccination era, and this is where Ganga also mentioned, we need to look at the pandemic differently in the vaccination era, because the link between infections and hospital admissions will break down as vaccination coverage increases. And this is, of course, assuming that no variants causing higher proportion of severe disease emerge. So what are the implications of that? One of the important implication would be to alter our metrics for measuring the epidemic based on vaccine coverage. And this should be included apart from maybe testing rates, etc., to assess the impact or to assess the severity of the epidemic. And I would completely agree to refocus in the vaccination era to hospitalizations and severe illness. And this would mean the metrics really changes from case positivity rates to, say, number of ICU admissions per 100,000 population, or critical illness 100,000 population, etc. So that's one point in the vaccine era which we need to really look at, trying to balance it for mobility restrictions or whatever interventions we plan. I would completely agree with endemicity, maybe use a term like conflagration state for that, where you have a steady state of moderate level endemicity, where large segments of populations are still under vaccinated in terms of 2 doses, coupled with robust spread of CoV2. But then that actually also gives opportunity for CoV2 to replicate with a chance for emergence of variants, which needs to be monitored proactively by the genome sequencing, etc. The key balance looking forward in the vaccination era is to accept that certain level of transmission is going to happen in the community, and we should contain or that we are comfortable with, that will not overwhelm our containment strategy and healthcare infrastructure or capacity, and allow social and economic activities to function. So this is a very delicate balance that we have to really strategize and think about what level of transmission in the community we can really expect. A few other points is there is emerging literature on various interventions and their impact on community transmission rates, etc., available in the literature, which is growing. And it's across the world. So we should be focusing on evidence-based interventions that are socially, geographically, and culturally acceptable and implementable to keep the levels of transmission and hospitalizations low. The other point I would like to mention, which perhaps has not been really been the focus across the country, is community engagement and public and community engagement in policy development. And unfortunately, policy comes from top side down, and the community is really left to grapple with itself, to adapt itself to the policy. But it always would be better to assess the needs of the community, both in terms of transmission risk as well as social and economic impact, and develop a policy based on engaging with the community. The other point is whatever implementation programs we do, whether it's in healthcare delivery or whether it is in transmission prevention or containment strategies, it has to be coupled with implementation research. Unless and until we are able to determine the effectiveness of whatever implementations we do, we will not be able to really have an evidence base to sustain those implementation strategies, or perhaps if they are really effective, to really amplify that across to other states and perhaps even national policy. Another issue is effective communication strategy with the public via media or directly is something which I thought was lacking throughout this epidemic. And this effective communication strategy is difficult because the dynamic nature of science involved in this epidemic, which brings mistrust actually in the public. When it started with WHO mentioning initially masks are not needed, to then making it very mandatory that we should be looking at masks, I think this communication strategy has to be extremely balanced. Of course, it should also tell them our successes in trying to contain this epidemic, but at the same time mentioning that it's a long drawn battle, and that would perhaps be important to prevent fatigue and vaccine hesitancy. Another point I would mention is, as far as prevention is concerned, we are always looking at all or none phenomena. We are looking at lockdown, no lockdown, etc. But I think it's time to have a translational implementation strategy, a hybrid strategy. For example, in a workplace, you may have a hybrid strategy which combines both work from home as well as working in person. So all of these issues are really important before we really think about immediately opening, etc., and to look at the implementability and collecting the evidence of the effectiveness of these interventions. So again, I would come down to the important issue about metrics, and the metrics, I think now in the vaccination era, should incorporate full vaccination coverage rate, not single dose vaccination, and look at hospitalization rather than case fatality, rather than case positivity rate. Layered strategies are actually important. No single intervention is effective. There are various papers. There's a meta-analysis looking at in workplace, where they looked at a combination of various strategies and was actually better than a single strategy. Masking alone in that meta-analysis was shown not to be effective. It has to be combined with surveillance and environmental adjustments like ventilation, etc. So no single strategy works. If at all, for containment strategy, we need to have a layered mitigation strategy. As far as vaccination is concerned, since it's such an important era, and I would see COVID era as pre and post vaccination, which dynamically changes the epidemiology as far as at least hospitalization and severe illness is concerned. It perhaps would be interesting at the policy level to look at whether we can mandate vaccination, a compulsory vaccination to perhaps incentivize people also to attend schools, colleges, to assess public services, or unavoidable closed congregated settings like malls, to return to work, to access tourism, etc. So at a policy level, maybe to reduce vaccine hesitancy as well, when we incentivize people that this is what is, if you get vaccinated, available to you to as far as returning to normal life is concerned, this is something which may help you. So that would perhaps reduce vaccine hesitancy. Testing strategy, I think apart from what has been said with RT-PCR, it may be interesting to pilot repeated home-based rapid antigen testing. There are modeling studies suggesting that even in spite of poor sensitivity or specificity of repeated home-based and rapid antigen tests may actually reduce infections and mortality at a justifiable cost. This actually data is from the US, but then we can look at doing our own cost benefit analysis. And finally, as far as genomic sequencing is concerned, I think the question asked in the discussion paper was who should be really sequenced. And I think all of those vaccine breakthrough infections, especially those who are hospitalized and have severe illness, because that is not the property of the vaccine. The vaccine is able to avoid hospitalization and severe illness to a significant proportion. So that all of those patients should be really sequenced for looking at emergence of variants. We also know that whole genome sequencing is a costly exercise. It has a very long turnaround time. So there are alternative platforms available which can be implemented in routine labs. And one of that is actually published in the Journal of Clinical Virology, looking at rapid RT-PCR variant assay, which actually incorporates known mutations of concerns with melting curve analysis. It's something which gives you rapid results. You can do it on all your positive samples and get a more robust data available about what variants are really circulating in our population. So I think I'll end there by just saying that we need to look at a multi-pronged strategy involving the public, involving the community in our policy development. We need to look at how vaccine alters the pandemic situation, and we alter our even infection and prevention control policies based on this altered epidemic or endemic, whatever you may need to call it in future, to open up and perhaps try to return back to normal life. Thank you.
Thanks, Sanjay Pujari. It seems that a sort of convergence of idea is taking place here as the presentations are progressing. Essentially, what is happening is that the presenters are generally saying that we should have a pre-vaccine and post-vaccine era. Now we are in the vaccine era, and in the vaccine era, our metrics should change. We need not be afraid of infection per se, but we should be concerned more about the severity of infection, hospital admission, and death. This is a strategical approach which they are suggesting. And as far as the community engagement is concerned, we may alert Sanjay Pujari that our local self-government institutions are very robust, and they act as a vehicle for community engagement, very successful community engagement and community education in Kerala. Now, next we have to move on to Dr. Giridhar Babu. As I said earlier, I was reading his article this morning that appeared in Wire. Giridhar Babu is the professor and head life course epidemiology and Public Health Foundation of India.
Thank you, sir. Respected Chief Minister, respected Health Minister, and all the dignitaries and brothers and sisters, as rightly pointed out. I just want to congratulate Kerala, but I'm not here to do that alone because Kerala is setting up a model for the rest of the country and probably some other countries also. I would want to summarize what I want to at least request Kerala government is in terms of the acronym model. Mortality reduction should be the only goal in terms of managing COVID-19. And therefore, whatever requires for that, those will come under mortality reduction. That's why O is for ownership, which has been rightly shown both at the community level and at the state level in terms of how this can lead to a better success. Data integrity and transparency, you've been doing extremely well, but my focus is here to shift one gear and go to the next, which can inspire the other parts of the country and the world. Equity and leadership are the two last things. When I speak of evidence, I want your kind attention. If you can prioritize areas with low seroprevalence and low vaccination coverage by looking at your own data, because you are one of the few states where you have seroprevalence done continuously and also have vaccination coverage at a granular level. A simple 2x2 table will give you this kind of stratification to prioritize where you need to focus, and that can set up a model. We did this in Karnataka state where government hospitals were used as sentinel sites, and Kerala could do this in the long run in terms of instead of having this mass vaccination strategy, you can shift this into sentinel surveillance based approach where you will still know what the burden of infection is. Regarding vaccination, this is the only way where you can reduce the impact of future waves, including the current wave. And my, again, one request in terms of data integrity point of view is monitor the effective reproduction number, because that will tell you when it is going to likely emerge as an outbreak later, and other indicators anyway the state is doing. This, from the evidence point of view, what we want to know is where we move ahead from here. For that, one is sentinel-based surveillance. Second is in terms of antibody waning. What are the levels of antibodies in the population that you have? And among the vaccinated people in specific, what is that we need to look out for in the long run? Those studies can be initiated in Kerala. Regarding vaccination, the state is doing really well. Only thing is to prioritize in the areas where there is low seroprevalence. And even in vaccines, you might have to do some studies, which will again, from a futuristic point of view, how you can inspire the others. What is the duration of protection? What is the role of different vaccines in combinations as the studies happening in India? Can you extend that into Kerala? And since you have robust data, can you give more evidence much earlier? In terms of research, there are a lot of things that can be done in Kerala, but I would not go into the details for the paucity of time. But one aspect I would want to request the government is to set up long follow-ups of the cohorts that you can build from the existing data and look at evidence both in terms of vaccinated and unvaccinated, and how in terms of even the sequencing results, things are changing as a cohort follow-up is done. Don't rely on one single model. I congratulate you for inviting all the experts here, and something similar to what US does, ensemble approach, getting all the models together, getting all the opinions together, and then having a Kerala specific forecast, which can then probably influence the rest of the country. This is how the other countries are doing. At least we can look at a developed state implementing this. Much has been told about endemic management. I'll not touch on it, but this is the time to start One Health approach and integrating surveillance for all the diseases together, because COVID-19 is not just going to be one disease management. With this, I'll stop my inputs. And again, I congratulate your efforts. But what is the point in stopping after being so successful when you can influence and inspire, continue to inspire the rest of the country and other countries? Thank you for this opportunity.
Well, thanks a lot. It was a very thought-provoking presentation, because you have suggested large areas, possible areas for research. We will focus on that. Fortunately, we have in Kerala a large number of research institutes and the universities. They combine together, may be able to do this research work. And you have also suggested about vulnerability appraisal and also reliable forecasting methodologies, etc. I mean, a lot of areas where hard research need to be done has been suggested. We will definitely look into it, and we would like to have another detailed discussion with you in the very near future. subject to your availability. Thank you, sir. Now is Dr. Shahid Jamil, who is the Chief Executive Officer at the Wellcome Trust DBT India Alliance. I was fortunate to listen to his inaugural address of KSSP recently.
Thank you, Dr. Iqbal, and thank you, Honorable Chief Minister, Health Minister, and the Government of Kerala for really putting together this group. And your seriousness and your success really reflects in your ability to hear opinions across a wide spectrum. So thank you for that. Everything useful has been said. So let me just reiterate 2 or 3 points. The first point we talked about is schools and who should schools be open to. Look at the data. The data, if you look at the risk versus age, that graph is a J-shaped graph, and the base of the J is 10-year-olds. So basically 6 to 13-year-olds have the lowest risk, which essentially, so the data essentially supports the fact that you start opening with primary schools. So that really would be the data-based approach. And of course, an all or none model is not going to possibly work. You may give the option, you may have a mixed model where you can have some students attending online, those who can afford to be online, those who can access online, but a large percent of our population that cannot access online schooling. So for them, it's important to be in school. We are forgetting that even when schools were closed, there was very little statistical difference between seropositivity rates in children and adults. So if we're trying to protect children by letting them not go to school, data shows that they're not being protected. So I think it's time to open schools. The second point is about what to sequence. And it's really very clear that what you want to sequence is vaccine breakthroughs. What you want to sequence is people who have had the infection once and they come down with infection again, because that will tell you if a virus is evolving that is evading pre-existing immunity. And that's really what you care about. If there is vaccine failure, that's what you care about. You don't want any virus evolving, and if it has evolved, not spreading, that can evade pre-existing immunity. And much has also been said about how well Kerala has managed, and truly it has managed well. But also look at the fact that roughly 12% of your population is confirmed COVID positive. You have to worry about long COVID in 10 to 30% of this population if you look at global figures. So prepare your health systems for that. That will be equally important. I mean, reducing mortality today is important, but also reducing mortality in the long run is important as well. And my final point is about when people say that we should go towards eradicating this virus, let us clearly understand that you cannot eradicate a virus that has animal reservoirs. The only viruses that have been eradicated from humans is smallpox and polio almost. And both smallpox and polio only circulate from human to human. They don't have animal reservoirs. The only cattle virus that has been eradicated is rinderpest, and that only circulates among cattle. So let's not talk about eradicating, let's talk about managing. This virus, like other viruses, will go into becoming endemic. Until it does that,
let us continue along the same path. Kerala has done very well, and yes, you may want to tweak your strategy based on vaccines available now versus earlier, but I think overall you're doing fine. So congratulations on that, and thank you for getting us together.
Thanks, sir. We are almost thinking on similar lines of what the suggestions you have said now. We are actually sequencing the breakthrough infection cases and repeated infection cases. We are doing spike protein sequencing and also whole genome sequencing very regularly. With regards to long COVID, sir, we are already well prepared for that. Starting from the primary healthcare centers up to medical colleges, we have already opened up long COVID clinics. And we are very well aware that maybe about 15% of the people have already had infection. They may be subjected to long COVID problems. Thanks a lot for your suggestions. We will follow this up with you. Now, next in line is Dr. Manoj Murhekar, who is the head epidemiology division at the National Institute of Epidemiology, ICMR. Hope he is present here. Manoj Murhekar. If not, I will move on to the next speaker. We can come back, always come back to Dr. Manoj later. Dr. Ramanan Lakshmi Narayanan, who is the Director, Center for Disease Dynamics, Economics and Policy. Dr. Ramanan. Unfortunately, he is also not here.
No, I'm here.
You are here. Thank you, sir.
Yeah. Just couldn't hear your question clearly.
Yeah. Thank you.
And I had some difficulty hearing the comment. Can you just repeat that for us?
No. I was just asking whether Dr. Ramanan Lakshmi Narayanan is here.
Oh, sorry. No. I'm on Rag. Sorry.
And also Manoj Murhekar. Then we will go to Dr. Swaroop Sarkar, who is an epidemiologist, public health expert, and a diplomat. Swaroop Sarkar. Okay. So, you are there. Sir, we cannot hear you, sir. Can you unmute and talk? You are not audible, sir. Dr. Swaroop Sarkar, he was here, but hoping that he may come back, we may move on to...
Can you hear me now?
Now we can hear you. Thank you. Thank you very much.
Hello?
Yes, sir.
Hello? Yeah, can you hear me?
Yes, we can hear you.
Okay, so I'll make 4 points. Many people have talked about the robust data of Kerala. What I think is the game-changing factor has been the culture and politics of transparency. And that goes beyond the data. I have a reason to believe that most of the states have the data, but none of them have been public to use this. So this is high time that we make a publication and documentation how in Nipah, early dengue 3 years back, and this time how publication and being transparent, not publication, the transparency has made a difference. And unfortunately, in my last role in WHO, I have fully documented Kerala's success on Nipah and dengue, and I don't see them yet published. So my first suggestion is ensure that the transparency remains and it gets a wider documentation how transparency has made a difference. Okay, number 1. Number 2 is we are assuming that Kerala is a homogeneous epidemic because of the population density and no rural-urban difference. We need to document that carefully. And I have not carefully looked at your state-specific survey, the data we had been quoting from ICMR study is not meant for state-specific survey. So can we have a state-specific survey and document the heterogeneity or homogeneity based on which the next stage of data collection would be local data collection, which is very much needed if the epidemic is heterogeneous. That leads to third point, which is the task shifting. Whenever you talk about local self-government, by task shifting, I mean also involving community organizations who do not report to the government, meaning they get money from the government, they work with the government, but they answer to their own, contracts and other things, often not controlled by the government. This is a general principle. So the time has come for long-term preparedness. So the community involvement through the CBOs, which we have seen in HIV very successfully in the country, and many organizations of leprosy, filariasis, or Kerala has shown a lead, and tuberculosis. So community involvement and community organizations is very important, and that must be structured, and they should be involved according to the local data. If somewhere epidemic is high, they get involved and take a full approach, including lockdown, and work with the administration. Where epidemic is very low, it can be all opened and everything. So a calibrated approach with a CBO response. And my last point would be, I think it's an important point, and I'm sure everybody knows this, but this has not been mentioned much. India has specifically a cohort, and some part of UK, or some time cohort of UK, that people got a vaccine in a 4 weeks difference of the Covishield or AstraZeneca virus. Their immunity is much, much different, and they need a special study and follow-up, and if needed, a special booster dose for them as a priority, including some of the house workers, etc. Prioritization, like the school teachers have been talked about. There are other group of co-transmitter who move from one house to another house, or transport worker. I'm sure many of these have been covered. So in your vaccine prioritization, this thing would come. These are my 4 points, and I'll be happy to write this for you, and some action points which have been working with other governments in the country on this. Over.
Please, sir, please send your note. We will look into that. With regards to state-specific survey, we have already initiated the state zero surveillance, and we hope to complete it by this month, and it will be published. With regard to publications, there is a dearth of publication from Kerala, and that we are looking into, and we will be doing it. As far as community-based organization, the major one in Kerala is the Kudumbashree, the self-help group, which are doing a lot of contribution to the COVID management, especially by organizing community kitchens and other services. Thank you. Thanks, sir. We hope that you will send your note to us also. Now, next is our good old friend, Dr. Murali Tumaripudi, who is an operations manager, crisis management branch, UN Environmental Program. Murali, we are very happy to have you with us now today.
Thank you, Dr. Iqbal. Good evening, Honorable Chief Minister. Good evening, Honorable Health Minister, other dignitaries and experts from around the world. Coming from the crisis management branch of the United Nations, and not being a technical expert on health itself, I look at this issue from a risk management point of view. This particular episode, health epidemic, therefore have 3 elements from my point of view. Number 1, issues relating to health, which includes mental health. Number 2, those are issues which are economic, labor, employment, schooling, all those. And number 3, the issue of communication strategy. A lot has been mentioned in this session, and I concur with most of it. Just to reinforce, I will take up 4 or 5 points. Number 1, I think it is now clear that using infection rate alone as a metric is counterproductive. If even after reaching 70% coverage of vaccination, the cases continue to rise and people are in this panic mode, and Kerala continue to get a bad press, then that is clearly a problem. That also creates a mental health fatigue. At the same time, from a communication point of view, if we were to unilaterally change the metric just because it appears not to put Kerala in a good shape, that is also a problem. From a risk management point of view, as Devika and others mentioned, it's clear that a conversion rate is a much better metric. So we need to define this metric clearly, and we need to have a communication strategy around it, including with opinion from these technical experts who are present here, so that it comes with their weight of authority. My second point is about school reopening. I think I fully agree with the experts that it is time that we consider school reopening. And again, we need a communication strategy. We probably need a 1 month time period to have that strategy lined up. I also agree that it should be the youngest first, partly because they are least vulnerable, but also because the loss of development of 1 year for a 5-year-old is much more severe than someone who is doing, second-year engineering. So clearly, it has to start from the younger age. Third point I want to mention is about the restrictions on movement. Currently, we have the curfew after 10 p.m. to 6 p.m. I have seen that happening in the Western world, but in those places, having nightclubs and massive sports and music events at that time is a concern. But since that's not a concern in Kerala, I do not see why we should have that restriction. I also do not really fully understand the rationale behind the Sunday lockdown. Is it supposed to be a circuit breaker? Is it effective? And I would clearly ask the team to look into the data and decide. But in terms of our overall strategy, it should be to expand the time available so that you spread the number of people coming rather than contract the number of hours. So the philosophy should be to have more time. The same context, we should also have an idea of reopening hotels and restaurants, maybe with 50% occupancy. This is what was done in other countries, including Switzerland. So initially it was 50% occupancy so that the economy got a rebound and the risk could be managed. Shops and other establishments were allowed to have on a per square meter area certain number of people, the electronic monitoring of it. Once again, I would recommend those things rather than having strict control on 20 people or 50 people. If it is something outdoor, you put one limitation. If it's indoor, right now, for example, in Switzerland, the limitation is that for any facility, 50% occupancy is allowed. So it's not about 20% indoor or 20% indoor or 50. It's about 50% of those people. I have just 2 points. One is about mental health issue. This is absolutely the National Health Service called the mental health tsunami, which is coming. On the back of it, we can already see it. People are almost at the edge of their coping capacity. Also, they're fatigued. The final point is about having a roadmap. I think it is time that Kerala created a roadmap of sort of an exit strategy from the current lockdown, reopening of schools, reopening of economy, so that even if the reopening do not happen on 1st of October, people know there's a strategy, it is coming. Something between now to next 6 months or beginning of next year, so that people start to feel there's an end to all this and life will one day get back to normal. Thank you.
Thanks, Murali. In fact, you have talked about expansion versus contraction. So the question is that if you go on locking down, the people will crowd in the previous day or the next day. Rather, don't go for lockdown so much so that people can be evenly distributed so that transmission comes down. This is a point of debate. This has to be looked into. We will definitely look into many of the points you have raised. And mental health, several people have raised this. I think In Kerala, we are yet to look at mental health a little more seriously. Even though there are a large number of dynamic youngsters, mental health experts in Kerala, we will have to look at mental health a little more closely. And definitely we will prepare a roadmap really, and we will consult you also for preparing that. Now that we have almost finished with the international and national experts, we have to move to the state level experts. And we may start with Dr. Chandini, who happens to be the chairperson, State Medical Board, and head of the Department of Medicine and Emergency Medicine in Calicut Medical College, Dr. Chandini.
Thank you, Iqbal sir. Honorable Chief Minister, Health Minister, and all the dignitaries and the experts, international and national. Thank you for this opportunity. It was great learning, listening to all the experts across the globe. And I'll be moving on because we have already highlighted the importance of COVID appropriate behavior, preventive strategies. And in Kerala, from the very beginning, the specific focus was on preventing overcrowding in the hospitals, affordable treatment, accessible treatment to everyone, and thirdly, reducing deaths. So we had a specific strategies with regard to treatment of these patients. For prevention, now we have vaccination, but earlier, obviously, the interventions were on the in the lead, but the vaccination strategies we have started, we have included the vulnerable group first, elderly, then even in 18 to 45, we have been focusing on people with comorbidities first and then covering everyone above 18 years, including pregnant females. So there was a strategic planning with regard to vaccination as a preventive strategy. And now we emphasize on early diagnosis. Early diagnosis is important today because we have monoclonal antibodies, and our institutions are also giving monoclonal antibodies in those people who are having comorbidities or who are likely to die when they develop a severe disease with COVID-19. And along with that, we emphasize on management of comorbidities because we have seen in our analysis that that was happening more in people with comorbidities, especially diabetes, hypertension, and cardiovascular disease. So this emphasis is done from the beginning. So we have an augmented surveillance of these comorbidities, and there is a home care management that is more focusing early diagnosis, early treatment, and control of all this, and also monitoring of these patients, especially with home monitoring for the oxygenation as well as the comorbidities and control of these things. And the patients are moved right time so that we could avoid unacceptable delay and preventing death. Treatment guidelines and protocols, we started the first guideline in January 2020, and it has been revised because the evidence is moving with regard to drugs and uses and other things, testing strategies. So as accordingly, we have now we have the version 4 of treatment protocol. So we include what the drugs to be used. And in fact, we have been using steroids at a very early age. And we are very thankful to CSIR IGIB, Dr. Anurag Akarwal is here, and also with Dr. Vinod Skaria. We have been very fortunate. In June, July, we had the first set of sequencing done 2020. And then from December 2020, we have been doing a monthly sequencing of samples across the state. So now we know where we are moving, and we have been able to tell what is the prevalence and what is the Delta variant in Kerala. And also we are focusing more on immune escapes as well as closely following severe illness and closely following new variants. And the other point I would like to emphasize, the indicators, many of the earlier experts have emphasized, we are focusing closely on hospital admissions, ICU admissions, ventilator requirement, oxygen requirement, and also monitoring deaths. What is the cause for death and what is the vaccination level and what is there any delay in hospitalization. So these are some of the indicators we have included. And we have a program for long COVID, which is already highlighted by Iqbal sir. And also now we have to look more closely on non-COVID issues, especially the diabetes, hypertension and other things, cancer, palliative care, all those things has to come into because we have to live with it for a little more longer. And the other programs, health programs like immunization is also emphasized. Thank you so much.
Chandini was associated with the Nipah control in Kerala and Calicut, and the state medical board she is heading is in charge of preparing the treatment protocols in line with the suggestions given by the ICMR and WHO. Now, let me now call upon Dr. Anup Vaidya, who is with the Aster Medicity.
Good evening, Dr. Iqbal, and good evening, friends. So basically, most of what has to be said has been said, but I'll try to reiterate a couple of them and add a couple of important points which I feel is necessary from my opinion. So since we had a very clear schedule in terms of 6 headings which has to be discussed, I'll go as per that. So the first point was about mobility restrictions, and I echo Mr. Murali's comments that since once we accept 2 things, that COVID is here to stay, and all of us are on the same boat on that, all of us agree COVID is here to stay, and 2, that we are going to achieve 100% vaccination in a couple of days, weeks, or even maybe months. Once these two things are understood, then we have no place for something like a lockdown in our management strategy. Super spreader events have to be looked upon very harshly. So other than focusing on the super spreader events, for the routine businesses should be able to function in a reasonable way. So that's my comment on the mobility restrictions. The second part was occupancy restrictions. And in this, I have something to add. So when we look at the risk, and I'm talking about the risk of indoor transmission. So we know that there are only 2 strategies which have proven to be successful in breaking this indoor transmission. One was adherence to masking, proper masking, and second is about ventilation. Now, it is a very well accepted theory in infectious diseases and infection prevention that engineering controls always fare better and are more reliable than relying on personal protective equipment and human behavior. So of this, ventilation, improving ventilation is an engineering measure strategy, which is long-term sustainable and will be cost-effective. Now, the World Health Organization has come out with a publication in, I think, February or March of this year, which has laid down a roadmap for all organizations at different levels, at organizational or a hospital level, at state government level, and even at national level, to look at how indoor air ventilation has to be improved, what are the steps, what kind of assessment you need to take. So I think we can set a precedent by initiating this thing in our state also. We have done similarly for fire audits. We have regular inspections and standards based on what kind of prevention or protection the building takes to prevent fires, right? So in the similar fashion, you can have an implementation strategy like fire NOC or fire audit looking at indoor ventilation. When you look at the how much of occupancy is accepted and how much is overcrowding, the most reliable and published data on this comes from measurement of ambient carbon dioxide methods, CO2 measurement, ambient CO2 measurement, which has been shown in a couple of papers to reflect overcrowding and as a corollary, reflect higher risk of transmission. So again, so indoor air ventilation, WHO's roadmap, and the cost-effective ways of looking at whether overcrowding is there or not is something which I wanted to focus. Coming back to mask, and this was something our first speaker alluded to, that the difference between the cloth mask and the need of FFP2 or N95 mask. So once we accept that indoor air transmission, especially in the setting of either poor ventilation or uncertain state of ventilation, is airborne, then obviously the level of mask you require would be different. So that is something, because we are all been focusing on cloth mask and double masking. Coming to vaccination, just a point in terms of boosters, because there is a lot of queries and controversies regarding need of boosters. Right now, I think we should focus only on immunocompromised like transplant recipients, because they have been known to mount a poor immune response even with the primary schedule. Other than that, I do not think we should consider boosters for regular healthy people, including healthcare workers, primarily because we understand that present available vaccine is a disease prevention or a death reducing vaccine and not an infection preventing vaccine. So once we know that, I don't think we should keep on trying to give on booster doses and keep the antibody levels higher throughout our life. And we know the recent data that vaccination plus natural immunity is sort of the best anyway. Coming to the testing strategy, just maybe a concern or a query because of my ignorance. I'm not sure whether we have a very robust system of quality control and management of the rapid antigen test kits, especially when we move on to home care and at the periphery and at the ground level, because it requires batch validation, and sometimes in our setting we have seen that batch to batch validation fails, and we have to change our providers base because the batch testing failed. Then coming to the fact of school reopening and college, the Royal College of Pediatric Health on their website, they have very nicely summarized all the literature available looking at the pediatric transmission up to end of July, I think July 25th or 26th of 2021. So it's as recent as a month ago. And they summarize that the risk of transmission between child to child and risk of transmission between child to adult is actually least between the age group of 5 to 15. Okay? So that is our school going age. So with the available literature it suggests that the risk of transmission between child to child or from the child coming back to home is actually least at between the age of 5 to 15. It is a very strong reason for us to definitely reopen our schools. We need to ensure that we create a sort of a vaccine ring by insisting and ensuring that all adults involved in this whole business, both at home and at school, are completely vaccinated. I would not advise repeated screening tests for children in the school, because again, if we accept the fact that COVID is here to stay, when will we stop these tests? So I would go more by a syndrome and the identification of symptoms and then test, rather than routine testing on a sequential way. And the last part was about the genome sequencing. And here I just reiterate that the priority group should be breakthrough infections who necessitate hospitalization, ICU care, or death. These should definitely be focused for our genotype. And the second priority should be the reinfections also who require hospitalization or ICU admission. Thank you, Dr.
Thanks, Dr. Anup. You have raised a large number of issues. I am not referring to them, but I assure you that the State COVID Expert Committee shall have a one-to-one discussion with you in the very near future, so that we can further work on these issues. Thank you very much. Now we are supposed to close this session by 7:30. Our Honorable Chief Minister and Health Ministers are very patiently attending this webinar for the last 2.5 hours. Before me, there is a list of 12 experts from Kerala. One group, the public health group, and the second one, those who are directly associated with managing the COVID cases, most of them infectious disease experts. So I am taking the liberty to pick a few of them to express themselves, assuring the others that we will have another opportunity to hear your views. So I am at random selecting a few persons for their opinions. Please confine yourself to 2 or 3 minutes. Now the first I may call Dr. Ashwati, Professor and Head of the Department of Amrita Institute. She belongs to the public health discipline. Dr. Ashwati.
Yeah, thank you, sir. Honorable Chief Minister, Honorable Health Minister, it is indeed an honor to be here. And from a few studies that we did in alignment with the Unity Protocol of WHO, we have also found that the incubation period is quite short now, maybe up to 3 to 5 days. And also with the Delta variant, we were able to identify it from the urine. So having said that, all the speakers have covered all the ground and nothing more to add, except to say that, yeah, closures should be on the way out, and we should be opening up in a controlled manner. Though how much that is possible in a democracy remains to be seen. And the working of schools is also necessary in a hybrid manner, perhaps, with maybe a part of which maybe a few days a week could be online and a few days could be in the school, because children really, they need to, for the psychosocial development, it's very important for them to meet each other and to grow as they meet and have fun and play. And of course, with the masks and all the other, with the teachers immunized and everything. Yeah, as before we open the schools, it may cause a lot of dread among the patients, among the parents as well. So it would be very important to give measured communication to the parents right from the beginning, so that they are sensitized to the need to open the schools. So with that, thank you, sir. Thank you for the opportunity.
Thank you very much, Dr. Ashwati. May I now call Dr. Rajalakshmi, who is an ID expert in KIMS.
Thank you, sir. Honorable Chief Minister and Honorable Health Minister, thank you for all. I would go in line with what Dr. Anup has said, the easy implementation wherever we can, even in school, let it be an open school so that we can open school at the earliest. We have faced a lot of mental health problems among the children and among teens as well, because they have, I think, lost the art of communication. So school opening is possible with 30% attendance. We can have 3 cohorts in whichever age group or which we plan to open, and 2 cohort can be attending an alternate day, and the 3rd cohort who doesn't want to for some reason can still attend virtually. So at a time, only 30% physical attendance is needed. And if those classes are recorded, it can be virtual as well as physical. That is the way forward. We should open at least on a specific age group and then open up for other classes. And we should make sure that the school windows are open, and so that air exchange is maintained and the masks are maintained, and vaccination for all the school employees as well as the household. That is mandatory. That should be mandatory. With that, I think we should open up school. And second thing is, if you are going forward with many of the self-testing, we have to look at the quality of testing and the reporting. And also the third thing is to make sure that all those tested positive is somehow linked to a doctor by telehealth, because so that we pick up each and every patient sitting at home before they come to hospital. We want to treat them at the earliest, between 5th and 7th day, so that we don't have surges. So we have to connect each and every patient tested and the household who are not tested, so that we can treat them, pick up the symptoms, so that we can avoid hospitalization and ICU admissions. And with that, I will stop, because I think many of this is addressed in the previous speakers. Thank you so much.
Thanks, Dr. Rajalakshmi. From the public health group, I may invite Dr. Biju Soman, who is the additional professor, Achievement and Center for.
Thank you, sir. And it has been a very educating section for us. I'm not going on to the suggestions, but I would like to raise 3 points. First and foremost, about the potential for sentinel surveillance. That is a quite feasible option. Actually, in Kerala, we can do that. And in Kerala, we all appreciated the government for this data transparency. I also agree with that. But I still feel that more can be deduced from this data if much more data or anonymized data is made available for the researchers like us or the other medical college people. Anonymized data can be made available, and more we can infer from the data, and that might lead to understanding the enigma of COVID in Kerala in much more better way. And third thing actually is the time that we had to go for One Health approach. Now focusing on 1 or 2 diseases which flare up is happening in Kerala, but we at the same time so many other issues, especially non-communicable diseases. Actually, all the diabetics, hypertension, their control is under deranged. So we have to look at that. So One Health approach we have to bring in. And my third point is that we have to think about what we should do with Ayush. There's quite a lot of human resources there, and they're willing to come and help with us. And probably many of them have come up with their own solutions. Probably this is the time that government should come up with a plan to engage them in a meaningful way, and whatever effort they are doing, that should be looked into in a scientific way. That is very, very important. And my fourth point is that it's time that we had to use our telemedicine facilities quite a long. We have e-health, and within e-health, CDAC has already incorporated telemedicine. And if we can make that all the follow-ups, if possible through telemedicine, that should be done through telemedicine. That way we can bring down the crowding in the hospitals. Thank you, sir.
Thanks, Viju Soman, for your information. The telemedicine, the e-Sanjeevani program is functioning fairly well in Kerala. That is very well being run. And also thanks for mentioning One Health. Now they are talking in terms of One Health, One World approach. Nobody has mentioned it. That is in the new normal period, we'll have to talk about One Health, One World approach. And may I also call upon Dr. Mahesh from MIMS Calicut. Dr. Mahesh, if he is not available, Deepu from Amrita Medical College, Kochi. Dr. Fasil Abu Bakr.
Good evening, everyone. I would not again extend the same things what has been told by the previous speakers. I just would like to say that this is a post-vaccination era, or we are going into a post-vaccination era, and opening up is probably the strategy forward. So, and schools, again, as the previous speakers have mentioned, that the transmissions in pediatric age group is less. So schools has to be reopened, and probably may make arrangements for vaccinating the adults involved in school children. That is household vaccination. Maybe the schools can associate with an hospital and conduct vaccination camps in the schools itself for parents and grandparents who are staying with the children. So apart from these two suggestions, I don't have anything more to add. I think maybe go on to the next speaker.
It is already 7:31 in my.
Okay.
I'll be close here with your permission, because I assure you that all whom we have contacted already, we will call them for discussion later, maybe in groups or something like this. We assure you that we will do that. We also wanted to have a question and answer session with the seniors who are here, but unfortunately the time is too late. It was a very exciting and educative experience. There was a proper mix of the clinicians, the public health expert, even the health economists. And we not only talked about the medical issues, we also talked about the economic and social issues, mental health, etc. We talked about very esoteric issues like genome sequencing, but also about school admission, school reopening, etc. It was very educative. But unfortunately, even if anything is good, even if it is good, has to end at some point of time. So we'll have to end, and I have to thank the Chief Minister and the Honorable Chief Minister and the Health Minister for being with us for the last 2.5 hours. It might have been a great strain on them. And the Health Minister has reminded me to tell this audience that we have a very effective system of counseling of the children. Even though they are not going to school, there's a very effective system of counseling going on. And now, may I call upon Dr. Our Health Secretary, Rajan Kobragade, who was working tirelessly for the last 1.5 years on health.
Before that, I would like to request our Honorable Chief Minister, sir, for his
Exactly. I thought about it, Rajan. Thank you, Rajan. I thought about it, but I was a bit diffident to ask him to do that, because
we will request. So, sir, over to you, sir. We would like to have some comment from you, sir.
മുഖ്യമന്ത്രി ഏതാനും വാക്കുകൾ പറഞ്ഞാൽ വളരെ സന്തോഷമായിരിക്കും. ഹെൽത്ത് സെക്രട്ടറിക്കും പറയാവുന്നതേ ഉള്ളൂ. ഞാനത് പറയാൻ മടിച്ചത് ഇത്രയും വൈകി പറയുന്നത് ഒരു അനൗചിത്യമാകുമോ എന്നുള്ളൊരു ഭയം കൊണ്ടായിരുന്നു.
Dear participants, let me thank you all for your insights and observations on the themes outlined by us. This has been a wide-ranging discussion, from the importance of investing in better quality masks to understanding what dominates student concerns during this pandemic, from safety protocols on opening up schools to changing strategy in the light of our increased vaccination program. We realize that we need to look into aspects beyond numbers, and in the post-vaccination period, strategies will have to change and responses will have to be dynamic. There were valuable suggestions on detecting new variants, developing new testing strategies, and the necessity to take evidence-based measures to sustainably reopen the economy. Our team and I will look at your suggestions carefully. We shall organize smaller groups that can go into more detail on the suggestions offered and produce practical policy prescriptions. I am certain that you will continue to engage with us. I would like to close by extending an invitation to all of you, especially our international and national participants, to visit Kerala in the future. Thanks for a very enlightening evening. Thank you all.
Health Minister, do you want to say anything? You are mute. You are mute, still mute. It appears that there is some technical problem at Health Minister's end. In which case, Rajan.
Yes, sir. We'll go for closure, sir. Yes, sir. Thank you, sir, for your whole conducting the program. Honorable Chief Minister Shri Pinarayi Vijayan, sir. Honorable Minister for Health and Family Welfare Srimati Veena George, Madam. Honorable Chief Secretary Dr. BP Joy. Honorable Chief Principal Secretary Dr. K.M. Abraham. All distinguished experts, senior officers, my colleagues, and Dr. Iqbal, sir. We appreciate the time taken by each one of you, especially all our distinguished experts from abroad, also from the country and Kerala, to share your views on COVID pandemic and for giving your valuable suggestions for working around COVID, setting the agenda for future. As our Honorable Chief Minister has said, we will definitely strive to take all your suggestions, study them, and definitely we will take them forward. Let me come to my responsibility. I, on behalf of all, and also behalf of Health Department, sincerely thank our Honorable Chief Minister, Shri Pinarayi Vijayan, sir, for providing his continued guidance and support in not only in fight against COVID, but overall response to this pandemic and to take us forward. We thank our Honorable Minister for Health, Srimati Veena George, for giving her support to take up various initiatives in the department, and we will continue to work to achieve the objective set by the government. I thank our Chief Secretary, Dr. BP Joy, who has been guiding us, monitoring our implementation and giving us a guidance to ensure that all the planned interventions are implemented at the grassroots level. We are grateful to all our distinguished experts for sparing their valuable time, because even with the very short notice, in fact, they have changed their schedule and they have joined us for this evening. And with their experience, in fact, we are enriched. I profusely thank each one of them for giving their valuable time for this discussions. We are also thankful all the invited dignitaries who have been with us fighting against COVID in Kerala. My sincere thanks to my colleague Shri Mir and others for organizing the roundtable discussion. Special thanks to Dr. K.M. Abraham, sir, for his guidance for taking us through this whole process. And lastly, I sincerely thank Dr. Iqbal, sir, Chairman of Expert Group, who has been with us in this journey throughout in our fight against COVID and for coordinating the discussions today. I thank each and every one, and with permission of Chairman, we will conclude this meeting here. Thank you very much.
Sorry, the Health Minister is now available. It is possible. Health Minister, are you available now? Yes. Oh, even now we are not hearing her. കേൾക്കുന്നില്ല. Okay. In which case, sorry. Sorry. Thanks, Chief Minister, once again for your patience to be with us patiently for the last 2.5 hours. So let us close this very valuable and informative webinar. We hope to have one-to-one discussion, group discussion with many who have come here later. Thank you very much.
Thank you.
Thank you, sir.
Thank you. Bye-bye.